I
so
know,
one of
I
the
always...
very fine glaucoma surgeons and a clinician. She will, so now Pradeep had told you about an advanced glaucoma and normal pressures. On the other hand, now Sagarika has to tell us very clearly whether I should treat a patient with maybe 24, 26, 28 pressures, but the field is normal, the disc is normal. So let us, we will not let Sagarika leave unless he clarifies for us what is happening here.
Thank you, Dr. Harsh. And since I always overshoot my time, I'm going to go straight into the talk. So he's already told you. How do I do it? So first of all, we have to define, Now, we have to define a particular thing, and that is what is ocular hypertension. Now, this is defined as consistently, the word is consistent, elevated intraocular pressure more than 21. He is fortunately given 24. 2 standard deviations above the mean population intraocular pressure. Again, by GAT, not by NCT or by any other means, on 2 or more occasions in 1 or both eyes, in the absence of any clinical evidence of optic nerve damage, field defect, or any other pathology, mind you, any other pathology that would explain the high intraocular pressure. So, most important, do a clinical examination. Why is it so important to study ocular hypertension? Because it has been shown to be the most important risk factor for the development of primary open angle glaucoma. So we don't have glaucoma still, but we merely have ocular hypertension, but it may result in glaucoma. And there's a huge amount of debate. Should we rename it? Should it be glaucoma suspect? Should we treat it? Should we not? What are the side effects? Should we treat with IOP lowering drugs? Should we do surgery for it? Etc., etc. Should we wait for glaucomatous damage to take place? Yes or no? What does the House say? Would you like to wait for glaucomatous damage? Raise your hands. None. Good. And therefore, or visual loss if it is not treated. So, therefore, the debate continues. Now, ocular hypertension study has beautifully answered these questions. They have told us who are the guys who are maybe at a greater risk of developing glaucoma. So, they have told us the predictive factors for development of individuals with ocular hypertension, and this is the first study to document that if you have a thinner cornea, which Dr. Pratik talked to us about, this predicts the development of POAG. So a CCT is a must for every patient. Suppose you combine all these factors, then you can identify patients who are at moderate to high risk for developing POAG and who are more likely to benefit from early treatment. Oates study suggests treatment is a must for patients whose pressure is higher than 24 mm of mercury among those who have greater than 2% annual risk of developing glaucoma. This is cost effective. I cannot but forget what Dr. Harsh had once upon a time talked about, that he had a patient who had ocular hypertension. He said, "Theek hai, tum chale jao, koi baat nahi." And that guy came back later with glaucoma. I will never forget it. So as a result, whenever I see ocular hypertension, I think about what he had said, because he has huge experience. What the medications that were used in the ocular hypertension study were beta-adrenergic antagonists, topical carbonic anhydrase, PG analogs, alpha-adrenergic agonists. Now, various risk factors have been seen, both in India as well as by the EPGS, and they have found that practically all the risk factors are same, whether it is older age, higher intraocular pressure, a greater vertical or horizontal cup disc ratio, greater pattern standard deviation on a standard automated perimetry, a thinner CCT, other risk factors like age, race, positive family history, low diastolic perfusion pressure, which Dr. Pratik has again talked about. And let's forget what we found in India. In the Chennai study, they found a higher incidence in the rural cohort as compared to the urban cohort. And we have to do diagnosis and follow-up of these ocular hypertension patients by doing a very important study, and that is your perimetry, standard automated perimetry and ophthalmic examination of the optic disc by a dilated examination. These are the gold standards. You have to follow up the patient like that and detect the patient whether the patient has glaucoma or not. You can also do earlier detection by other means like swab, FTT, SLO, etc. But whether or not these are really going to give you correct results, we still really don't know. Another test which I've never used, but I found it, and so okay, why not tell everyone and maybe check out on it, that is the ibopamine test has been reported to be an efficient provocative test in the management of glaucoma and patient risk. I really don't know. If anyone has any idea, please do let me know. There's a risk calculator also, which I remember many years ago was given to us, but unfortunately we never used it. Maybe you all have seen it also. I'm going to go to a patient, 53-year-old male. He had no comorbidities, no family history, no steroid use, found to have pressures of 36 and 37 in 2009, so many years ago. Now this man came back in 2018. His anterior segments were normal. He had open, grade 3 open angles. His diurnal variation varied between 18 and 20 in the right eye and 18 and 20 in the left eye. Absolutely normal. And mind you, these are all office diurnals. CCT was practically normal. He was in the right eye on 2 drugs, and rather 3 drugs, Zalacom and Dorzox in the left eye and on Zalacom. Now, this was his field in 2018. And this was his optic nerve. Very healthy. You can make it out. Even the retinal nerve fiber layers you can see. What about his OCT? I always like to do a baseline OCT. Gives me a lot more confidence that, okay, nothing is really wrong. Like, for example, Dr. Harsh saw my OCT and said, all green, SAGARIKA, fine, fair enough, no problem. So I do the same thing. But the thing is that you have to, when you see these patients, ask yourself some questions. What are they? What if this guy develops ocular surface problems when I'm giving so many drugs? What about the other side effects of AGMs? Remember, there are so many systemic side effects of AGMs which you cannot afford to forget. Should I really have treated this patient? Because there's a high prevalence of ocular hypertension. We know that. But a low conversion rate to POAG. Could we really have kept this patient on follow-up? Should the number of AGMs be reduced? What about the cost of treatment? Patient has to go and spend about maybe 500-600 or more than that every month on buying medicines. How long should we keep treating? Lifelong? I don't know. What should our target intraocular pressure be? We base our target intraocular pressure by looking at our field. We have no field defects at all. Should we contemplate surgery if the patient has got, let's say, a newly diagnosed hypertension? IOP is also uncontrolled. Now, in newly diagnosed ocular hypertension and POG patients, it may be a first viable option in those with poor compliance and who are intolerant. Mind you, lots of patients are intolerant. We have to recognize that intolerance and not give for, let's say, primary toxicity, lots of steroid ointments. No, please don't do that. What about cataract surgery for IOP control in OHT? Good treatment for visually significant cataract. What do you say, Dr. Harsh? Don't you agree with me? Yeah. So yes. Now there's another treatment which has come up, and that is the National Institute of Health, and the huge study was done, the LIGHT study, and they found that SLT is a very cost-effective alternative to ocular hypotensive drops. Very, very good. We may be able to apply that also. Now we're going to another patient. In 2006, this officer came to me. He was a 46-year-old male, that time Lieutenant Colonel. They call me Lieutenant Colonel now also in AIOS. Doesn't matter. He was a glaucoma suspect with 0.6% is to 1 in each eye. Normal fields, pressures normal, strong family history. Father had glaucoma, vision normal, gonioscopy, open angles. DV was practically normal, little bit of high raised pressure of like maybe 22, 24. And he had little thick corneas. Look at it, 582, 584, 583. In 2006, fields normal, kept on follow-up, no treatment. Okay, in 2012, in the army, we keep traveling from place to place. Some of us are not very, very familiar with fields. So this guy was probably not too familiar with the fields. And so he saw this defect, which was right in the center. He said, okay, glaucoma. And so he started treating the patient with medicines. And so then started this man on medicines. That's what happens all over India. It's not just the poor army guy. Okay. In 2016, once again, that guy was now on just one drug. No field defects seen in both eyes. We went down to 2019. No field defects. The guy was now on plenty of medication. I'll come to that. 2022, the guy came back to me. I'd seen him first in 2006. And now I find absolutely within normal limits. So the ophthalmologist stayed the medicines first from Timolol, which he was on. And then that became Travacom. And why? The pressures were 19 and 17. I don't know. Maybe he measured the pressure on NCT, found it, doesn't matter. Then in 2013, another drug was added, Dorzox T to Travatan. So Travatan, Dorzox T, fair enough. Then OCTs were being done annually, normal, but this guy developed PEDs, in 2014. So now comes the VR surgeon into the picture. In 2018 in RPC, his vision, the DV was 17 to 18, fields were absolutely normal, fundus at 0.6, but now look at the optic disc. Now mind you, this has been seen in RPC. Optic cup changed from 0.6 to 0.8, documented. And he had superior neuroretinal rim thinning. Now, because of the PEDs and because the guy had to be given injection Lucentis, so the drugs had to be changed. So you have to examine the patient, check back what is happening to that guy in some other portions of the eye. And so the drug was changed from, they changed it from the prostaglandin analogs to Dorzox T and Alphagan P. In 2022, we find his vision is very good, absolutely normal, excepting for a little bit of changes which are taking place in the retina. IOP is within normal limits, fields are normal, and of course he is on those medications. So what are the lessons we are learning? Please counsel every patient. Very important follow-up. Just can you remove that little thingammy, please? Oh, sorry friends. Change AGMs only when required, depending upon the diurnal control or development of other diseases. Our glaucoma patients are going to continue, and mind you, the retina is going to be affected by God knows what all. If they have diabetes is going to happen. So many things are going to happen. So therefore, you have to keep on and on alternating. We have got to see what will suit the patient or not. Be prepared for the unseen. The pressure in optic nerve head changes. You have to consider options for treatment. And therefore, I think, rest my case, therefore, I would like to treat. Because patients keep on moving from place to place. One person cannot observe the patient for so long. Therefore, it's better to treat because then you safeguard the patient. Of course, this is always a debate. I stand my case. Thank you.
Thank you, Sagarika. Thank you very much for finishing well in time and with so much enthusiasm. Your enthusiasm is infectious. So basically what the crux of the matter is that you get a patient with normal visual fields, normal disc, and let us say normal OCT. And if the pressures are below 24, 25, if there is no family history of glaucoma, I think one may still, and if you talk to the patient that, okay, you can later get glaucoma, and please, what Sagarika was telling was, that ये मेरे पेशेंट को 624 का कॉर्नियल थिकनेस था, तो हमें पढ़ाया गया था इफ़ द कॉर्निया इज थिक इतना इतना माइनस कर लो, हमने माइनस किया, वो 24 का बन गया 18, हमने कहा वेरी गुड, परफेक्ट. एंड दैट पेशेंट आई लेफ्ट, एंड 1 year later he came back to me, luckily only with a wedge defect, and there was only very early OCT changes. So the question is, do not get misled by a thick CCT. Do not get misled. Okay? So all these patients have to be very, very regularly followed. But again, like she said, medication itself is an issue. So you have to discuss with the patient, and believe me, every doctor that I have treated, he wants treatment. He doesn't want to get observed. But lots of patients as such would say, okay sir, I don't want any medication. I will regularly come to you every 3 months, every 6 months, that's fine. So if a patient is having any pressure above 27, 28, irrespective of anything else, straight away has to be started on treatment, field normal, disc normal, OCT normal, finish. Matter ends there. If it is around 24 to 26, then you will see, is there a positive family history? And the positive family history doesn't mean, अरे वो दादा को शायद हुआ था पता नहीं, not that. We want papers. When you see the papers, then you realize whether actually it was just nothing. So many times it was nothing and they are correlating it with something else. So don't go on that. So you have to be sure that if there are some other changes, if there are some intermittent pressure, so you need a diurnal variation to know what exactly is the highest pressure. This is one of the most important indications of doing a full diurnal variation, so that you know that the highest pressure is rising to this much. If it is rising above 27, 28, even if everything else is, we will start one medication definitely. If it is not, we will just follow up and make sure that he is following up. If you know that he may not follow up, then like Sagarika said, put on treatment, safer there. Thank you very much, Sagarika. You can run for that.